pleasure to be here again, but on a very important topic this time, talking about our bone health. We're focusing on a very silent problem that is incredibly important. The goal of today would be to give you the information, to keep it very clear, but so that you feel empowered to start doing and implementing the changes necessary to keep.
Now.
Oh, can I ask you to please mute yourselves? Great, thank you. All right, so let's get started. So most women don't realize that they have any bone loss until, unfortunately, a fracture happens. This is why education and also early detection, early intervention is critical. From the age of around 50, around half of women will experience a fracture during their lifetimes. That doesn't mean that half of 50-year-olds have a fracture, but it means going, throughout their life, above 50, they have 1 in 2 chance of getting a fracture. And it's largely driven by postmenopausal bone loss, making osteoporosis one of the most common and preventable chronic conditions that we see amongst women. Menopause is a key turning point, and bone loss speeds up significantly, particularly in the first decade, in the first between 5 to 10 years in your menopausal journey. Now, I'll concentrate on estrogen here, and in this hour, we're concentrating on estrogen, the main female sex hormone, and its importance in our bone health and what happens when it declines. But of course, there are other important hormones as well, progesterone and testosterone, and I'll be going into those as well, because I think one of the things that is missed quite regularly is the importance of non-estrogenic hormones in maintaining bone health and in prevention of osteoporosis and osteopenia. So estrogen is central to bone protection. When the levels drop, we see that the bone breakdown exceeds bone formation. So continuously in our bones, things, they're not static. There are bone cells are breaking down, bone cells are being built, and there are various cells that help in that activity. I've just put a couple of names there. The name of the cells that make bone is called osteoblasts, and osteoclasts are bone cells that break down the bone, and they're constantly in sort of equilibrium and in communication with one another, and there needs to be a balance between both osteoblasts and osteoclasts in order for our bones to remain fresh and strong throughout our life. And estrogen has an action on both of these kinds of bone cells, both osteoblasts and osteoclasts. It has receptors on them for estrogen, and it improves absorption of calcium from our diet. So it's really, really important in maintaining the strength in our bone and the structure of our bone. Progesterone is not sort of commonly considered to be a bone active hormone, and nobody really goes into it or talks about it. It's actually crucial that we have a good balance of a good quantity of progesterone in our blood levels, especially for those who may have early signs of bone loss, osteopenia. As I said, bone health is all to do with formation of new bone and in preservation of the bone that we have. And progesterone is the main hormone that supports the formation side of it. So it has a direct effect on osteoblastic activity, the bone forming cells, and it complements estrogen's protective effect as well. In menopause, actually in perimenopause, which is a decade before we hit menopause, women often start having anovulatory cycle. So they don't ovulate with every cycle. And if you don't ovulate, you don't make any progesterone. And that's why the sort of the first and the accelerated bone loss actually starts in perimenopause and is often missed, because that's when women are still having regular or maybe a little bit irregular cycles, but they may not know that they're actually in hormone declining or bone lossing phase of life. Progesterone often declines even quicker than estrogen in perimenopausal state, and it reduces the osteoblastic stimulation, and it stops any new bone from forming. Testosterone is another hormone that is extremely important in a woman, often known as a male hormone, and of course men have a lot more of it, but all women synthesize, make new testosterone, and they need testosterone for their various aspects of their health, especially when it comes to bone and skeletal health. Testosterone has both direct skeletal effects and indirect functional benefits as well. It enhances the cortical bone integrity. Cortex is the outer layer of bone. So in any sort of long bone that we have in our body, there's the outer part that is called the cortex or the compact bone. It is the very hard outer layer, and it gives us like almost 80% of the skeletal mass comes from that. And then inside the core of the bone is quite spongy, and it's called the trabecular bone. So what testosterone does is that it keeps the integrity of the cortex, of the outer thick, strong layer of bone. And it also improves the lean muscle mass, which is critical for fall prevention. So what we're trying to do in perimenopause and menopause is not only maintain and preserve our bone health, also as we age, we want to stop or prevent falls, which is the #1 cause of morbidity and mortality in very old age. In clinical practice, it is particularly relevant in women with low libido, with fatigue, and with muscle loss, sarcopenia. And when you optimize your testosterone level, that provides broader musculoskeletal benefits. So it's not just for your bone health, but for musculoskeletal. And yeah, so it's really important to check testosterone levels and to start replacing it if we see that the levels are declining, especially in the context of bone health. So after menopause, we have about 10% bone loss in the first 5 years of once you've hit the menopause, and that's when you haven't had menstrual bleeding for 12 consecutive months. And that spongy bone part, the inside of the bone, is affected first in the spine, and that puts you at an increased risk of fractures. This is why early intervention is the crucial part. So there's a window of opportunity, and often, we talk about menopause, but I hope we can reach a stage where women are getting checked before they become menopausal. And for those who have a genetic predisposition for early bone loss or for osteoporosis, osteopenia, they can intervene as early as possible before they hit critical bone loss years. What are some of the risk factors for osteoporosis? This is early menopause. So if early menopause can be between 40 to 45, we call it early, and premature is when it occurs below the age of 40. And there's various reasons for this. Some women are genetically inclined to have an early menopause. So we often follow our moms or first degree female relatives at the age for the age for which we reach the menopause. And some people can be pushed into early menopause secondary to physical or psychological trauma, or perhaps due to some medical treatment. For example, cancer treatment with radiotherapy or chemotherapy can bring about an early menopause. And it's really important in these circumstances for a woman to have a discussion around their bone health and how they can prevent the osteoporosis that can result from that. If you have a family history of osteoporosis, you have that. That's not a vague, like, grandmother having osteoporosis above the age of 80. Either your usually mom and an early onset osteoporosis that's under the age of like 65. Or multiple first-degree female relatives having osteoporosis as well. Low BMI, body mass index, and you can calculate yours by dividing your weight in kilogram by your height in meters squared. And if it's a low BMI, that puts you at a higher risk. Smoking and regular alcoholic beverage consumption, or if you have a sedentary lifestyle. So many women really underestimate the risk because they feel, family history, they feel well and they don't see that there's any changes to their, because it's invisible. It's very, very similar to blood pressure. When we regularly ask women to check their blood pressure for their review consultations in menopause clinic, and they often say, yeah, I was checked a few years ago and I don't have headaches or vertigo or something like that. But that's the very later stages of high blood pressure, and you don't necessarily see anything, and that's why it's important to check it. The same goes with bone health. It's important to check so that intervention can start earlier age. So what are the main pillars for strong bone? And here's our listed. HRT, estrogen replacement, is just one of them. The very important is, and we'll go into details of each one of them, is nutrition, your exercise, supplements that you can take as well, and medical support, depending on why you have developed osteoporosis, or if you know that you have a genetic predisposition to have that support earlier on. And if you have this in your head, that it's the various pillars that provide you with that optimal bone health is a good picture to have, because it's a framework which simplifies everything, and you can tap into it and remember that you actually have to, look after various aspects of your health in order to optimize your bone health. If you just don't remember anything else from today's talk, I think if you have this in your head, that this picture from this slide would be great, because it will encourage you then to pay attention to various aspects and make sure that you've optimized, especially if you are interested in optimizing your bone density. So when it comes to nutrition, it works really well when these are pillars, and you really need each one to work synergistically with one another. When we talk about nutrition, the first thing is calcium, and often I get asked, how much calcium and which food have calcium in them. So I know we've squashed the different pictures here, but it's just to give you an idea. It's not just dairy for those people who have maybe lactose intolerance or dairy allergies and they can't take it. There are many other non-dairy products that are extremely high in calcium that you may not have thought about them. Things like fruit, oranges, kiwi fruit, some vegetables, leafy vegetables, nuts. So there's various food kinds that have high levels of calcium, and they can be very beneficial for bone health. And a lot of women, again, underestimate the intake. Just because you have some, milk with your hot drinks, coffee, tea, or you have a little bit of cheese, it doesn't mean that you are taking the right quantity or your calcium level is optimized. Supplements may be needed if your dietary intake is not enough. Vitamin D, again, it's a really important vitamin and supplement, especially for those of us living mainly in, we work indoors and the long dark months in the UK. So what I've put up here, which is 800 to 1,000 international units per day, that's for maintenance. And a lot of over-the-counter vitamin D supplements contain this quantity of vitamin D. So this is not enough for those who have a deficiency of vitamin D. Depending on and as we enter our menopause or in later stages of perimenopause, you want to be optimized. So like everything else, like any other hormonal range, vitamin D range is also quite wide. But if you're hovering around the lower end, that's even not enough to have, up to 1,000 international units per day. You really need to step it up. And depending on how much you're deficient or what you're trying to optimize to the level that you need to have that conversation with your healthcare provider, with your GP, menopause specialist, to get that right quantity. And it's vitamin D3 that you want. I will talk about K2. K2 is often nowadays mixed in with D3, and it helps the vitamin D to deposit in your bone cells. Protein is often overlooked, but it is really critical for both bone health and for fall prevention, because it helps not only in building the matrix of the bone, but it helps in strengthening your muscular structure as well. And then we come to the micronutrients. A lot of women that, I see, my patients, they're very good at taking magnesium. It's, as even for those women who are taking HRT, they often have deficiencies in some major micronutrients and major vitamins, like the activated B vitamins, B complexes, and also magnesium, zinc, and omega-3. And it's really important that we don't overlook that, and we don't just assume because we're taking HRT that we don't need to take supplements and micronutrients. It's good, if you haven't had this discussion, to actually bring it into one of your review appointments, to a consultation, and ask to optimize from this side as well. These support your bone metabolism, and they help utilize calcium as well. So they really work synergistically, and they help one another, very similar to the way hormones work. I always say that we can't look at individual hormones in isolation. It's great if for example, your estrogen is at an optimal level, but even more importantly than that is to make sure that you are balanced with all hormones across the board, not just optimized with one single one. The same goes when we talk about supplements and vitamins and nutrients. And now on the topic of the very important, the most powerful intervention that you can do, exercise. Exercise is medicine, really, when it comes to your bone health. And even if you do 2 or 3 sessions per week, it can make a significant difference to the bone density. So it's all about consistency, and not quite, if you can intensify your work and lift more weights and what, great, but it's being consistent, and make sure that you do some of whatever that we've listed there times a week. That fall prevention is just as important as your bone strength. So you need to do a combination of resistance training, which builds your bone density. It improves your strength, but also weight-bearing exercises like walking and jogging, just bearing your own weight. That is mainly these type of weight-bearing exercises is for maintaining your bone density, not for adding bone to your. And I think we'll come to that again. Balance, again, we're talking about long-term fall prevention, and also flexibility and mobility by doing some form of Pilates or yoga, which supports your joint health. And what is the role of HRT, hormone replacement therapy? It is often the first line in symptomatic women. So if you have quite significant or frequent symptoms of menopause, like hot flushes, night sweats, like insomnia, or maybe anxiety, these are as a result of a fall in your hormone levels, whether it's estrogen, progesterone, testosterone, or a combination of these. But also, it is the fall in these hormones that kickstarts the whole process of osteopenia and osteoporosis. So replacing hormones in the absence, of course, of any particular risk factor, you have to be risk assessed individually, but it can have a significant effect on prevention of bone loss, in reducing the risk of fracture, and of course, on the side, symptomatic management of menopausal. And if everything, who should be for HRT is individualized. So we can't, everybody has a different genetic predisposition to various diseases, and they also have various background and past medical history. So everything needs to be considered. But if you have symptomatic menopause, if you have early menopause, needs to be considered and dealt with in its own merit. So and unfortunately, I see women, on every couple of months that have entered menopause many years ago, and because they weren't symptomatic, they weren't considered for any HRT. And it's only when they've come to, in their 60s, or a couple of ladies I saw recently, they were in their 70s, that they wanted to consider HRT for some symptoms that had started, but they had missed that opportunity to act as prevention, HRT to act as prevention of, as well as bone density, for dementia, for heart disease, for increase in cholesterol and blood pressure. So I think it's, we know that people who start their menopause at an earlier age than average, which is about 50 to 52, they're at higher risk of developing chronic diseases, and they really need to consider taking HRT even in the absence of any significant menopausal symptoms. And the non-HRT options, there are plenty of them. I've named the top 3 here on this slide. They're used when HRT is not suitable, or perhaps additional protection may be needed. Some women choose not to take HRT as well. They don't, but they still want to have some bone protection, or treatment for their osteopenia or osteoporosis. Bisphosphonates, just very quickly, it binds to the bone cells, and it's almost like a poison for osteoclasts, for those cells that break down the bone. So it stops the breakdown. It has some side effects. The very common one is GI irritation or gastrointestinal reflux, but the rarer but very, very serious side effect is osteonecrosis of the jaw. And that's why it's important for people to have a full dental checkup before they get started on bisphosphonates, because if they need any dental treatment, they should do it before getting started on bisphosphonates. But it's a first-line treatment, and it's the one that is offered by majority of the GPs as well for women who are established in osteoporosis. And then denosumab, that's it's basically another blockade of osteoclastic formation. So it blocks the formation of the cells that break down the bone. They all work in very similar ways, but different sites, basically. One of the serious side effects from this medication is that you can get rebound vertebral fractures if it's stopped abruptly. So if you're coming off it, it needs to be done under medical supervision, and you need to be weaned off it. And then we have the selective estrogen receptor modulators, but they're not estrogens, but they mimic the effect of estrogen on bone. So they prevent it from breaking down. So they're not there to make new bone, but they stop the breakdown of bone. and they're not HRT. You may have heard of DEXA scan as a way of investigating our bone density. It basically it's really important for risk assessment and monitoring of how the treatment that you're on, how well it's, whether or not it's effective and how much it's effective. It identifies osteopenia and osteoporosis. And of course, as I said, it's important in the diagnosis and for monitoring of treatment as well. Just very briefly, because I know, I see, and I'm just basically sharing with you what I hear in consultations for women who've had various issues with their bone health, or they come to me with their DEXA scan and they want to help to have a rough understanding of what these numbers mean and what the scores mean. There's two main scores that are usually talked about on a report, on a DEXA scan report. The main one is T-score, for those of you who may have had this type of investigation, or maybe that you know about the T-score. But it's basically, T-score tells us how strong our bones are compared to a healthy young adult at peak bone strength. So if you think about it like this, that you're being compared to a gold standard of bone health, so someone between the ages of 25 to 30. So the further below you are, so the normal bone density is +1 to 0. That's normal. So that means that your bone density is very similar to someone around the age of 25 to 30, and you may be around whatever, about 40, 50, 60 when you're having this bone density. And osteopenia, or step before osteoporosis, is when the score is between -1 to -2.5. That's osteopenia. So this early bone thinning is not osteoporosis yet, but it's a warning sign, and you can reverse it at this point. And then osteoporosis is when the T-score is below -2.5. And that's when your bones are significantly weaker and you're at higher risk of fracture without trauma. So prevention should be our ultimate goal. Early identification of people who are at risk of developing osteoporosis, investigating them properly, implementing the treatment early enough. This is all what would prevent fractures in the future. So if you just want a very simple action plan that you can do is to eat well, make sure you include the calcium-rich, vitamin D-rich food in your diet. You need to move regularly. Even, just moving around, bearing your own weight is definitely helpful. And optimizing your hormones for those who don't have a particular risk factor for it. So the takeaway messages should be that estrogen is central to our bone health, bearing in mind that progesterone and testosterone also have an important role to play. And nutrition and exercise are foundational, and they're extremely important, and they need to be as for those who are taking HRT, they need to be considered as important as their HRT. HRT is, of course, highly effective because it's replacing the chemicals, the hormones that have resulted in the thinning of the bone, and early action prevents fractures for sure. So early detection of osteopenia, or even before that, for someone who's going for any major surgeries of gynecological organs, maybe they're having a hysterectomy, oophorectomy, which is removal of the ovaries for whatever reason, they're at a younger age, they need to know that they have to have a plan in place in order to prevent osteoporosis and fractures in the future. I think you know about our approach. We do there are many women that may think they're not suitable for HRT for various reasons, but there's many various types of HRT, and I think it's important to be aware of that, and that it can be custom made for you as well. The HRT based on your history, on your genetic background, and your blood levels as well. Now, that was a quick trip around bone